Hello everyone, I am Dr. Shefali Tyagi. Today we are here to discuss NEET 2022 OBGYN questions. Since for upcoming NEET, these constitute the most important topics, we will discuss them in detail. But I understand the crunch of time, so we will be touching only on the important topics, which are the potential questions, right? Okay, so let's start with the first question. Identify the type of hymen in the given image. It's a previous question, it has been asked previously, the same question exactly. So, which type of hymen is this? The options are annular hymen, septate, imperforate, cribriform. First of all, let's see how the hymen is formed and then we will see the normal type of hymen followed by what are abnormal types, okay? So, basically how the hymen is formed. When your uterovaginal canal starts going downwards, it comes and joins with your urogenital sinus, okay? So, vagina starts forming at around 12 weeks, okay? At 3 months of gestation it starts forming. So, when uterovaginal canal comes down and connect to the urogenital sinus, where does it connect? It connects in the posterior part where there is a tubercle called as Mullerian tubercle. So, this sinovaginal bulb has a Mullerian tubercle where the uterovaginal canal comes and attach. What happens now when it attaches, the Mullerian tubercle starts growing and the endometrial tissue starts matching with that of the uterovaginal canal. So, when this grows, and the endometrial tissue of this sinovaginal bulb grows, it forms, of this Mullerian tubercle grows, it forms sinovaginal bulb. So, sinovaginal bulb is also lined by the same endometrial tissue as of UV canal. So, it is a part of UV canal only. Now, how the hymen is formed? Eventually, this sinovaginal bulb is canalized. So, hymen is nothing but the junction between this sinovaginal bulb and the urogenital sinus. This is the place of hymen. Can you see? This is your hymen, where the sinovaginal bulb is connecting with the urogenital sinus. So, the hymen is an area above which the vagina is formed by uterovaginal canal because these are the same parts, and below hymen it is by urogenital sinus. Okay, that is the area of hymen. Now, hymen is generally half moon shaped or you can say crescentric shape. Okay, that is a normal shape of hymen. There could be other variations like annular hymen. So, this is annular hymen in which instead of being half moon shaped, the hymen is circular. Okay, it is surrounding whole of the vaginal canal. As such, it does not pose with any pathological abnormality. Okay, it is just a normal variant. This is annular. Now, hymen can be imperforate. If this is the condition, patient will have cryptomenorrhea. She will be having amenorrhea with lot of cyclical abdominal pain. Okay, and you have to do hymenoplasty. So, this is imperforate hymen. This is microperforate, a small hole is there. So, menses will be there, but patient will have problem in putting tampons and will have problem during intercourse. Same with the cribriform hymen. She will have menses, but she will have dyspareunia. Also with the septate hymen. So, they all have similar presentation and they all need surgery called as hymenoplasty. Okay. So, the answer was the septate hymen. Next question. Woman brought to emergency 5 days after her normal vaginal delivery. She is having history of crying, loss of appetite, difficulty in sleeping, low self-esteem. Okay. Her general physical examination is normal, pelvic examination is normal. What do you suspect? By her postpartum symptoms. Okay. Some psychological illness is there that we can know. When it has started after 4 days. Okay. Yeah. Puerperal blues, manic depression, neurosis or psychosis. For knowing this, we should know the psychological problem that can happen in puerperium. So, basically puerperal psychological problems are 3. Okay. Either it could be postpartum blues, it could be postpartum depression or it could be psychosis. Okay. So, let's see the difference. The postpartum blue is very common. It is seen almost in 50 to 70%. It is so common of women after delivery. It typically starts after 4 to 5 days of delivery. That is when it starts. Okay. Patient will have crying. Okay. She'll be crying, she'll be depressed and she'll not feel sleepy. She'll be having a lot of anxiety. So, these are the typical symptoms of postpartum blues. The main feature is that she'll be crying a lot and she'll be having a lot of anxiety. So, it is a very common thing. Why? Because it is present in 50 to 70% women, starts almost 4 to 5 days post delivery, and when it resolves on its own. Within 24 to 48 hours it resolves. So, you do not need treatment, but the women need rest. She does need rest and sleep and that will cure her symptoms in 24 to 48 hours. Okay, that is postpartum blues. Now, postpartum depression is actually a depressive illness but a non-psychotic one. If there is non-psychotic depression present, when it is present, so it has generally two peaks. One, it presents at 2 to 4 weeks. So it is a late presentation at 2 to 4 weeks, or it could be present at 8 to 10 weeks. So there is late presentation with proper depressive symptoms. She will be fatigued, she will not be feeling entertained in any of the things, she will have a lot of anxiety, she will be most of the time depressed and crying. So that is with late presentation, that is postpartum depression. So the incidence is almost 10% with a late peak of 2 to 4 weeks and 8 to 10 weeks. So this depressive illness need treatment. And what will you give? It will not resolve on its own. You need SSRIs, antidepressant SSRIs, in which the most safe is sertraline. So sertraline is your drug of choice in postpartum depressive illness. Okay. Postpartum psychosis is rare, only 0.05 to 0.1%. It's so rare. It is psychotic symptoms. The question will typically give you that patient has hallucinations, she has mania. Okay, they'll give you psychotic symptoms of the patient. It is an emergency. Patient is dangerous for the baby and for her own life. So it's an emergency. You have to immediately admit such a patient who will give you the symptoms of again depression and crying and the hallucinations or auditory or visual hallucinations or signs of mania will be there. That is postpartum psychosis. Present also at 2 to 4 weeks. It also presents at 2 to 4 weeks. It's an emergency, so that you have to admit the patient and you have to start the patient on antipsychotics like lithium, electroconvulsive therapy, valproate may also be started. So though patient might be breastfeeding, you will not stop her from taking her medication. Breastfeeding will be stopped in lithium and electroconvulsive therapy, but patient need antipsychotic. Okay. So what was the question? She presented in 5 days. So it was early presentation with crying, loss of appetite, difficulty in sleeping. So it's simple postpartum blues, right? Okay, it is not psychosis or depression. While giving traction to the structure in the given procedure, the structure got torn and led to excessive vaginal bleeding. What is this structure? It is umbilical cord. So it got torn and bleeding was there. Obviously, what will you do? So in such a case, when the cord got torn and the bleeding starts, will you do massage? Will you do oxytocin? You'll arrange blood and do Creedy's method or manual removal of placenta. So let's see how to manage when the cord gets torn off. So if that is happened, patient will start bleeding. Obviously, there is placental tissue inside. So you will immediately catheterize the patient. You will start massaging the fundus. Why? Is that the treatment? No. You will massage the fundus till you do any definitive treatment. Now, definitive treatment will obviously be the removal of placenta. Okay, until you remove, the bleeding will not stop. So, you have to shift the patient in the operation theatres. This patient has to be taken to operation theatre because you can remove placenta only under general anesthesia. Okay, under general anesthesia, uterus will relax, then only you can remove the placenta manually. Okay, unless the patient is shifted to OT, you will give the massage and you will give oxytocin also. So they are adjunctive treatment, but they are not the definitive treatment. Okay, definitive treatment is manual removal. And how it is done? You will introduce your right hand into a layer and you trying to find a layer between the placenta and the uterus, and in a slicing manner with your palm forwards, you will slice the placenta from the uterine wall. Important, your left hand will be resting on the fundus, because with your left hand, you will guide the fundus towards the right hand. You will not make your right hand to move and reach the fundus, because this time the uterus is so soft that even your hand can perforate the uterus. Okay, so your left hand will guide the fundus towards your right hand, and on the slicing manner you will remove the placenta, which is the definitive treatment. Sometimes if you are not able to find a layer, suppose there is no plane of cleavage is found, it means it's a placenta accreta, and now what do you have to do? You have to take the patient for hysterectomy. Okay, so yeah. So uterine massage will be done, oxytocin will be done, because till you are shifting the patient to OT, they are adjunctive treatment, but the definitive is that you will remove the placenta manually. Okay. Now, arrange the blood and do Creedy's method. So Creedy's method is that of a fundal pressure. When you do not remove placenta from below, you press the fundus and try to squeeze out the placenta. When it is done when the cord is very thin and fragile, like in very preterm or in IUD baby. in those conditions, very preterm or in IUD baby, you do CRED method because the cord is so fragile you cannot pull the cord. Then you do CRED method and try to squeeze out the placenta. So it is not a choice here, okay? Which among the following condition is a contraindication for application of this contraceptive? Okay, so it's a simple question on contraindication of a copper IUCD. What is this IUCD? It's multi-load, right? It's multi-load. Now let's see the option: trophoblastic disease, menstruation, condom rupture following delivery. Let's see one by one. Is copper IUCD a contraindicated in menstruation? No. You can very well apply copper IUCD or any IUCD during the menstruation also. Okay, in fact, it has been seen that because the cervix is soft and dilated, you can easily introduce the copper IUCD. Though expulsion rates are high, but you can safely introduce it during the menstruation also. It's not a contraindication. Condom rupture. So, condom rupture during intercourse means patient needs emergency contraceptive. So, is this an emergency contraceptive? Yes, in fact, it is the most effective emergency contraceptive. Okay, among levonorgestrel, among ulipristal acetate, which we have for emergency contraception, the copper IUCD is the best one, can be inserted within 5 days of intercourse. Is Mirena emergency contraceptive? No. Hormone releasing IUCD is not an emergency contraceptive. Only copper containing IUCD is emergency contraceptive. Okay, so it is not a contraindication. Following delivery, you can introduce IUCD following delivery, right? Immediately after delivery, within 48 hours. So the guidelines are within 48 hours of delivery you can introduce. If you have missed those 48 hours, now you cannot introduce IUCD till 4 weeks, till a month. Then you have to wait till 28 days and after that you can introduce. So following delivery means post placental, you can definitely introduce a copper CD. Trophoblastic disease is an absolute contraindication. Why? Because in a GTD, it has been seen that uterus is so soft. If after suction, you will introduce an IUCD, you can very easily perforate. So IUCD is not an option in GTD. In fact, in GTD, OCPs are also not given because it has been seen that if you give a GTD patient OCPs, the chances of converting that trophoblastic disease into choriocarcinoma are high. Okay, so that is why OCPs are also contraindicated in gestational trophoblastic disease. The contraceptive of choice in GTD is actually barrier contraception. Okay, so remember this, that in GTD, barrier contraception is the contraceptive of choice. So absolute contraindications of IUCD are pregnancy, undiagnosed vaginal bleeding, current PID and STI, not past PID, current PID, postpartum sepsis, carcinoma cervix and carcinoma endometrium. Okay, fibroid uterus is not a contraindication. Nulliparity is not a contraindication. Now, a 59-year-old woman presents with anogenital warts like this. Genotype of the virus has been done and it signifies that she has a risk of atypical squamous cell carcinoma. What will be your diagnosis? Now, if you have read this question in a rush, then you will just see the genotype of the virus has been asked. It is what? What will be there? 11. So, the low risk HPV 6 and 11 are the most common causative viruses for warts. But you will miss that line that she has been seen to be at risk of squamous cell carcinoma. The low risk HPV do not cause cancer. So, she is not associated with HPV 11. It is actually HPV 18. So, HPV are of two types, low risk and high risk. Low risk are 6, 11, 42, 43, 44, which are basically associated with genital warts. Genital warts is a very common STD. Okay, so it is associated with genital warts and not any type of cancer. So, the high risk HPV, which is 16, 18, 31, 33 and so on. So, there are 13 basic types of high risk HPV are associated with squamous cell cancer. Squamous cell cancer of cervix, vulva, vagina, penis, anus and also oropharyngeal cancer. Okay, so these types of squamous cell cancer could be caused by high risk HPV. But what about warts? It has been seen that 90% of genital warts are by low risk HPV 6 and 11. But occasionally warts can also be caused by high risk HPV, so like 16, 18, 31, 33 and 35. Okay, since these can also cause HPV, that is why our answer was HPV 16. Now anogenital warts are usually asymptomatic and they are clinically diagnosed. Generally, you do not need biopsy. Biopsy is done in warts only when you are not very sure of diagnosis or patient is immunocompromised or patient is not responding to treatment. Then only you do biopsy in warts. Why? Because even if you do biopsy, if it's low risk or high risk, it will not matter. The treatment will not be different, isn't it? So biopsy is not advised. So now there is certain do's and don'ts. What you have seen the patient has warts. Will you start doing pap smear frequently? No. So pap smear is done at a normal frequency in patients of what? Okay. The sex partner testing. The sex partner testing for HPV is not done. Okay, HPV is so common that sex partner might also be positive for HPV. Okay, so you will not test the partner for HPV. You will just do a local examination of genitalia to see any warts. Okay, then testing for other STD is done. Since it's an STD, you will test that patient for other STD. What about the vaccine? Gardasil 9, non-avalent Gardasil, is protective against warts, but it prevents against what? It will not treat. So you can give her Gardasil for prevention of any other type of HPV warts, but she will not be treated by this vaccine. Okay. The treatment of what is? Either you can apply local imicumod, podophylox, or trichloroacetic acid. Trichloroacetic acid can also be applied inside the vagina. Okay, for vaginal warts. Imicumod or podophylox can applied only on the skin outer side. Trichloroacetic acid, cryotherapy or surgical removal. They all are choice for warts. Yes. Next question. Identify the yellow colored plane in this given image. So this is our yellow colored plane. What is this area? Is it pelvic inlet? It is zone of mid pelvis? It is anatomical outlet? Or it is obstetric outlet? Okay? Yeah. So see, basically you can divide your pelvis into three parts. Inlet, mid cavity and outlet. Now inlet is from upper border of symphysis pubis to your ala of the sacrum. That is your inlet border. Okay? Then comes your cavity. Now the cavity starts from between the pubic symphysis up till S4, S5 is your cavity. Okay. Now cavity has two planes. So what are the two planes in the cavity? Plane of greatest pelvic dimension and plane of least pelvic dimension. So plane of greatest pelvic dimension is from, I hope you can see, midpoint of pubic symphysis passing through this obturator. Since it's a plane, so it's a complete area, three-dimensional. From here passing through the obturator area, from here up till S2, S3. So that is a plane of greatest pelvic dimension, the area in which the cavity has maximum dimensions. So it is not of that significance. So this area has the greatest dimension, it will not affect our labor process. Basically of clinical significance is plane of least pelvic dimension. It is also a part of cavity only. Now plane of least pelvic dimension starts from mid of the pubic symphysis, going through the ischial spine, reaching up to S4, S5. So this is the plane of least pelvic dimension. Okay, and it is the area which has the minimum diameter in cavity. Now this area is very important because head has to cross this area for a smooth delivery. Okay, so that's why we have discussed also that interischial distance is the area of plane of least pelvic dimension, right? Outlet is from lower border of symphysis pubis reaching through this area up till coccyx is the anatomical outlet, but coccyx is very mobile, it's not fixed. So obstetric outlet is from to the S5, that is the outlet area. Okay. Now let's see the question. The yellow area is basically from mid of the symphysis pubis to S2, S3, and this green area is from here to S4, S5. So what area is this yellow one? Pelvic inlet? No, pelvic inlet is this one. Zone of mid pelvis? Yes, it is the zone of mid pelvis. Anatomical outlet and obstetrical outlet are from coccyx to S5. This area is anatomical and obstetric outlet. Okay. So that's what we have discussed, that the cavity has two planes. Plane of great pelvic dimension from midpoint to S2, S3 and plane of least pelvic dimension from here to S4, S5, right? And obstetric outlet is from S5 to lower border of pubic symphysis, right? Next question. At what level the uterus is felt after second day of delivery? Okay, so it was a clinical question. The basic gist was that patient is day 2 post delivery where the uterus will be felt. Okay, so basically why it is important to know this, because post delivery you have to see whether uterus is involuting at a normal speed or not. So if you have to know whether it is abnormal or not, you have to know what is the normal speed of involution. So see, involution is basically return of the genital organs to its pre-pregnant state, that is specially involution. Okay, now involution is the process which starts immediately after delivery of the placenta. Now immediately after delivery it has been seen that uterus is 1 kg. Okay, excluding the fetus and the placenta, everything has moved, uterus is 1 kg. Okay, after 1 week uterus is 500 grams and after 2 weeks uterus is 300 grams. So at 2 weeks, uterus is intrapelvic. At 4 weeks, uterus is 100 grams. It means it has come to its pre-pregnant state. The involution is complete. So involution is complete at 4 weeks. Though the size of a non-pregnant uterus is 60 grams. But whenever involution occurs, the size, the end result of uterus is always little larger compared to what it was before pregnancy. So uterus of multipara is definitely little larger. So at 4 weeks, uterus is 100 gram and it is the complete involution. Now clinically, how will you assess it? So for clinical assessment, we have discussed this also, that immediately after delivery, the uterus comes to lie at the umbilicus. So uterus is just at the lower border of umbilicus immediately after delivery. And it stays there for 24 hours. It stays there for 24 hours. So on day 1, at the end of day 1, if you will palpate, you will feel it just below the umbilicus. Okay. Now the involution starts at rate of 1.25 centimeter per day. It means your 1 finger breadth per day. Okay. So 1 finger breadth or half inch per day is the normal size. Okay. So at day 1, you will find it at lower border of umbilicus because it is constant there for 24 hours. At day 2, it will be 1 finger breadth. At day 3, it will be 2 finger breadth. Okay. So here, your answer is, yeah. So at day 2, it should be 1 finger breadth below umbilicus because the rate is 1.25 centimeter per day after staying constant for 24 hours. Okay. Next question. A multigravida was in second stage of labor for more than 2 hours. Okay. On PV, the fetal head is palpable at ischial spine in right occipito transverse. Sagittal sutures are in transverse diameter, molding plus plus caput plus plus. What is this case? It's a case of deep transverse arrest. Head is at ischial spine in transverse diameter and the sagittal suture is in transverse diameter. It's a deep transverse arrest. So what will you do? Vacuum delivery, forceps delivery, LSCS, wait and watch. Let's see, wait and watch. Now she is in second stage, multigravida, more than 2 hours. Now it is a prolonged second stage. What is the definition? Second stage, more than 3 hours in primary and more than 2 hours in multi is prolonged. So it is prolonged second stage, you will not wait and watch. What will you do? Vacuum, forceps or LSCS? Let's see. So deep transverse arrest is generally seen in android pelvis. In android pelvis, the anterior pelvis is narrow, that is why the head is not able to rotate. So it rotates only 1/8 and comes to lie in a transverse plane and it is stuck there. Okay, now it cannot enter the cavity. Okay, now, so it is very common in android pelvis. Also, if the pelvic floor muscles are very lax or the contractions are not good or the baby is big, that time also the deep transverse arrest can occur. Now, how will you decide what to do? Now, with each contraction, if you see that a deep transverse arrest baby is below the ischial, so basically problem is it that the head is mal-rotated, right? Head is not rotated well. So you can accomplish delivery only if you can rotate the head and then you can deliver it. Am I right? You can rotate the head. Now for rotating the head, the instruments we have is the vacuum, rotational forceps, also the manual rotation. But for all those, the head has to be below the ischial spine, right? Head has to be below the ischial spine. You cannot apply all these instruments when head is at zero station, right? Head has to be below ischial spine. So if head is above ischial spine and it is arrested in a transverse plane, the only option is LSCS, okay? But if head is below ischial spine, you can very well try rotation using your hand, using the forceps, keel and forceps, or using vacuum. Now here they have clearly given that it is at the level of ischial spine. Also, molding is plus plus, caput is plus plus. It means there is some sort of disproportion. Either the pelvis is narrow or the baby is big. That is why molding and caput are plus plus. So you cannot use vacuum and forceps and your answer is LSCS, right? Next question. Middle-aged lady wants to conceive. Now lady has recently undergone surgery for vesicovaginal fistula. What recommendation will be given after VVF surgery? Abstinence for 3 weeks and avoid pregnancy for 2 years. Abstinence for 3 months and avoid pregnancy for 1 year. Abstinence for 6 weeks, avoid pregnancy for 6 years. Abstinence for 6 months, avoid pregnancy for 1 year. Okay, so let's see what are the guidelines which you have to follow after a VVF repair. So first of all, why does a vesicovaginal fistula occur? In developing country, the most common cause of VVF is obstetric, means obstructed labor. So obstructed labor is the most common cause of VVF in developing countries. In developed countries, the most common cause is surgery, that too simple hysterectomy. So simple hysterectomy is the most common cause, though the most risky hysterectomy that can lead to VVF is radical hysterectomy, but it is not very commonly done. So the most common cause is simple hysterectomy. Okay. Now, how the patient will present? If patient has VVF, patient will have constant dribbling of urine. Okay, so bladder will never be filled. She might not able be to go to urinate, as all the urine which is being collected will be seeping out through the vagina. So there will be constant dribbling of urine. Patient will be dry. There will be ammoniacal smell. Patient will have the lesions at the perineal area because constant urine dribbling. Okay. Now, so how will you manage? Suppose a patient had went into obstructed labor and she presents to you with fistula after some time. So in case of obstructed labor, you have to repair the fistula after 8 to 12 weeks. Okay. Now you were doing a surgery. Now this is a different condition. You were doing a surgery and fistula happened. You diagnosed it then and there. So if you have diagnosed it then and there, within 24 hours, you can repair immediately. Even in obstetric cause. If in obstetric cause you have diagnosed within 24 hours, you can immediately repair. Okay. But if 24 hours have passed, then around this fistula so much tissue edema develops that if you repair it afterwards, it will lead to failure. So after this 24 hours have passed, you have to wait for 8 to 12 weeks for repair. Okay. So this has been asked in questions previously in form of perineal tears, that when a perineal tear should be repaired. So for perineal tear also it is the same. If you have diagnosed it within 24 hours, repair it. If you have missed those 24 hours, now so much edema is there, you want it to get resolved, you will repair it after 8 to 12 weeks. Same here. So how will you send the patient home? She will be having constant dribbling, you will catheterize the patient. That too suprapubic catheterization. So you will put a long staying suprapubic catheter so that patient doesn't keep on dribbling. Okay, the lower area is dry, and you will call her after 8 to 12 weeks. Right, you will give her antibiotics also. And the procedures done are Ladsko and Chesser-Moyer technique. Okay, so these are the two procedures done for VVF. Now once the VVF has been done, the post-surgery care which you have to give to patient is continuous bladder drainage. So continuous bladder drainage is done for 2 weeks. Okay, so either do SPC or in some cases you can also do per urethral catheterization, but continuous drainage is needed. Once the catheter is removed, you will ask the patient to urinate very repeatedly because you do not want the bladder to distend and fistula repair to open up. So continuous repeated urination you will advise, you will give antibiotics and abstinence. There should be no sexual intercourse, no per speculum examination or PV examination till 3 months. Till 3 months you will not introduce speculum, you will not advise intercourse to that patient. What about pregnancy? The pregnancy has to be avoided for 1 year. So she has to avoid pregnancy for 1 year, and since VVF repair has been done, she cannot undergo vaginal delivery. It's an indication for cesarean. Okay. So your answer is 3 months for abstinence and 1 year for pregnancy. Yeah. Next, during embryological development, testis would release testosterone. Okay. Which among the following is responsible for releasing testosterone? Okay. So in a male fetus, how the testosterone is released? In a normal male, basically Leydig cells release the testosterone under influence of which hormone? LH. LH is being secreted from fetal pituitary. Now, intraembryonic time, who is the one which is releasing the testosterone? Is it LH from mother? Is it SCG from placenta? Is it GnRH from fetal hypothalamus or inhibin from corpus luteum? First of all, GnRH from hypothalamus is very less. In your embryonic life, your hypothalamic pituitary and the gonadal axis, hypothalamic pituitary gonadal axis is in an inhibited state because LH, FSH are being secreted in very less amount, but they are inhibiting GnRH. So GnRH is very less. It will not lead to the testosterone release. LH of mother will also not lead to testosterone release from the fetal testis. It is the HCG from placenta which has a structural similarity to LH that will stimulate the Leydig cells of fetus releasing the testosterone. Okay. Inhibin will also not help in that way. So the testosterone secretion during embryogenesis is influenced by HCG. So HCG stimulate Leydig cells along with fetal gonadotropin. So in conjunction with fetal pituitary is secreting small amount of gonadotropin. They are also helping in testosterone secretion. Along with that, the placental HCG is also acting. Now the option here was the gonadotropins were not there. LH from mother, SCG from placenta and GnRH from fetal hypothalamus. So they don't help. Only SCG from the placenta and gonadotropins from fetal pituitary. They together act and help in release of fetal testosterone. Okay. Now what are the basic functions of SCG? SCG is a glycoprotein hormone exclusively secreted by placenta. The highest amount is in 8 to 10 weeks. So it plays a very major role in protecting the corpus luteum. So corpus luteum is needed for progesterone. So it helps in protecting corpus luteum for progesterone secretion. Okay, after that work is taken by placenta. Also, it stimulates Leydig cells for male fetus, testosterone production, right? And it has got immunosuppressive activity to prevent immunorejection of the fetus, also involved in steroidogenesis and stimulates maternal thyroid activity also. So all these are important functions of HCG. Okay. Now question have been asked in INI-CT also on the hormones, the protein hormones secreted by placenta. That was the question in INI-CT. The proteins hormones secreted by placenta are many, but the most important protein hormone is HCG. Okay. So HCG is the most important protein hormone secreted. After that, human placental lactogen is secreted. All the hypothalamic releasing hormones are also secreted in small amount, like GnRH, growth hormone releasing hormone, corticotropin releasing hormone. They all are also secreted. Okay. The role of GnRH by placenta is mainly to stimulate SCG only. Okay. So the main function of GnRH of the placenta is to stimulate SCG secretion. Okay. The steroid hormones secreted by placenta are progesterone and estrogen. Right? Okay. Now, next question. A 22-year-old female present with complaint of recurrent pregnancy loss. SCG was this. What will be your diagnosis? Now you can see clearly SCG showing two uteruses. Okay. Bicornate uterus, it can be. Septate, yes, it can be septate. Since you cannot see the outer contour, you can see only two cavities. It could be septate or bicornuate. Okay. Didelphys, no. The didelphys uterus, I have told you in my classes, will have two cervix and two vagina. Didelphys, everything is two. So if you see two cannula showing two cervix, two vagina, that is didelphys. Okay. Unicornuate, no. You can see two horns, not uni. So these two are gone. Basically, you have to differentiate between bicornuate and septate. So how do you differentiate? So basically, on the ultrasound features, following are the differentiating points. So depth of the fundal contour, if it is less than 1 centimeter, it is septate. Similarly, if the fundal contour is convex or flat, it is septate. But if it is deep fundal, okay, it's an MRI point. It is bicornuate. Most important is that intercornual angle less than 75 is septate, more than 105 is bicornuate. The distance between the two horns, if it is less, it is septate. If it is more than 4 centimeter, it is bicornuate. Now see here. Now if you can see bicornuate, the horns are far away. Right, they are far away. The distance is more than 4 centimeter and the angle, can you see, such a wide angle of 105 degree. Whereas in septate, the horns are not wide. The angle is acute, less than 75. That is septate. Okay, so this is, can you see? So this is a bicornuate uterus. The horns are wide away, right? So regarding HSG, multiple questions has been asked in past. Okay, regarding uterine anomaly in recurrent pregnancy loss. Important points which I want you to remember is how to confirm the diagnosis of uterine anomaly. So for confirming the diagnosis, the most important is 3D ultrasound. Of any uterine anomaly, 3D ultrasound is diagnostic. If 3D ultrasound is not in the answer, then your best test is hystero plus lapro. Not only hysteroscopy, not only laparoscopy. Hysteroscopy plus laparoscopy is diagnostic. Okay. But better than that is 3D ultrasound. Further testing, if there is a uterine anomaly, you will test for further two systems, and that is your renal system by IVP and your spine. Okay, so those spinal X-ray. So these two systems are also checked because associated anomaly is present in almost 40% in renal cases and 10% in spinal cases. Surgery. So the question has been asked on the surgery of uterine anomaly. So uterine septum can be repaired two ways. Abdominally, you need to know about two surgeries, Jones metroplasty and Tompkins metroplasty. Just remember the name. The questions have been asked on these names only, Jones and Tompkins. The best procedure though of removing a uterine septum is hysteroscopy. Go through vagina, do a hysteroscopic septal resection. The question asked in past was, among which of these the normal delivery is allowed in future? Obviously, the abdominal surgery in which you open the abdomen, cut the septum, stitch the uterus, you cannot allow further normal delivery. These patients are indication for cesarean. But in hysteroscopic septoplasty, you will allow the patient to undergo vaginal delivery. So that was the question. In biconvex uterus, you will do Strassman metroplasty. Okay. What about uterus diadelphus? You will not repair uterus diadelphus because it's two uterine cavity, two cervix and two vagina. It's completely different. You will not be able to repair it. So this is uterus diadelphus. Can you see two cannulas, two cervix, vagina, two horns, right? And this is unicornuate, single horn. Okay. Yeah. Next question. Primary gravida having normal regular cycles present with amenorrhea for 6 weeks, followed by vaginal bleeding and right-sided pain. UPT is positive. Okay. UPT is positive. She is just 6 weeks, vaginal bleeding and pain. BP is normal, beta CGG is 1400. Now, ultrasound shows normal adnexa, trilaminar endometrium, means nothing was seen in ultrasound. What will be next step? So, what is this case? UPT is positive. On ultrasound, you cannot see anything. Patient has spotting and pain. It's a case of pregnancy of unknown location. Pregnancy is there, but you cannot locate where it is. Okay. So, how will you manage such a case? In this beta HCG level, will you do ultrasound after 3 days? Or will you repeat beta HCG after 48 hours? Or will you straight away go for laparoscopy or progesterone levels? The patient is stable. She has pain, no doubt. She might be ectopic, but she might not be ectopic. She might be just a patient who might be going to miscarry. She might be a patient of normal intrauterine pregnancy who is just having implantation bleeding. So you don't know. Patient's BP is stable. So it's not something of emergency. If the patient's BP has been low, okay, she has been hypotensive and collapsing, you will not think of what diagnosis is there. You will straight away go for laparoscopy because most likely it's ectopic. But in such a case, patient is asymptomatic. Okay, we have 3 conditions. It could be ectopic, it could be miscarriage, it could be normal. What will you do? The beta HCG is below the threshold. So what is the threshold for beta HCG? The beta HCG at which the uterus should show the pregnancy is that threshold. That is 1500 for TVS. Okay. If your beta HCG is 1500 and above, the TVS should show the pregnancy, the GSAC, and it is 6000 for transabdominal, right? But so our beta HCG is also less. So in that case, what will we do? We'll do expectant management. Right now, we'll wait. We will repeat the beta HCG after 48 hours. Why? We'll see how it is increasing. If it is doubling, the normal doubling is more than 66% in 48 hours. If it is doubling, it is a case of normal intrauterine pregnancy. Okay. If it is falling more than 50%, it is miscarriage. You will keep on following with beta HCG and you will see that it is falling. So it means patient has miscarried. Okay. But if the patient has rising beta HCG but it is not that optimal, or if it is falling but not that rapidly falling, it might be a case of ectopic. You are not sure. What will you do? You will repeat the beta HCG till you get this to this threshold level. As soon as your beta HCG cross this level, then you will do ultrasound. And now, if on ultrasound you cannot see anything, then it is ectopic. Because after this level, ultrasound should show something inside the uterine cavity, right? So, you will keep on repeating HCG here till you see something on ultrasound. So, what will you do here? Will you repeat USG after 3 days? No, you will repeat USG once it crosses the threshold. So, you will repeat the beta HCG because if it rises more than 66%, you know it is intrauterine. You will not do laparoscopy in a stable patient. What about serum progesterone? Now, serum progesterone is helpful in certain cases when your diagnosis is not very sure. It has been seen that progesterone more than 25 nanogram per ml is live pregnancy and less than 5 is miscarriage. Okay, when it is between 10 to 25, it might be ectopic. So, it might be helpful, but only when your diagnosis is not getting confirmed. Okay, so first step is repeat the beta HCG and see its rise and fall rate. Okay. Next question. A 38-year-old gravida to para 1 at 18 week 5 days presented for routine anomaly scan. Now anomaly scan shows cervix 115 mm. Okay. Now despite giving proper counseling that there is no benefit of cerclage, she is insisting on cerclage. Now which of the following is an absolute contraindication for her? Now her cervix is small, but she is G2P1. Any previous history of preterm or something is not given to her. That is why if you incidentally see cervix which is short, you will not advise cerclage. That is why in the question itself she was advised against the cerclage. Okay, but if the patient is insisting, the basic question it is asking is the contraindications of cervical cerclage. Advanced maternal age, positive fetal fibronectin, membranes bulging, ruptured membrane. Okay, let's see the cerclage. So cerclage is basically a prophylactic surgery in which you place a suture around cervix to prevent the preterm. Now types of cerclage could be vaginal or abdominal. Abdominal cerclage is done via laparoscopy or laparotomy, okay, when the suture is placed at the isthmus, okay, very high success rate. Vaginal cerclage could be McDonald, which is an easy one. You go as high you can go in the cervix and you place a purse string suture, simple. In Shirodkar, you pull up the bladder flap, you open the bladder flap and just at the level of internal os, just above the Macken rod, you apply purse string. So it is applied higher and the surgery needs more precision because you have to remove the bladder flap. That is Shirodkar cerclage. Now the indications are, basically indications of cerclage are two: history indicated or ultrasound indicated. History indicated means a patient comes to you and she gives you history that I had previous 3 preterm births. 3. So if she had 3 or more than 3 preterm births, you will straight away give her cerclage. Okay, when? At 11 to 14 weeks. Okay, so 3 at more than 3 at 11 to 14 weeks. Why at 11 to 14 weeks? Why not before that? Because at 11 to 14 weeks, you will do her first trimester ultrasound, you will do her dual marker, you will be 80% sure that the fetus has no anomaly, her Down syndrome test will be normal, then only you will give cerclage, okay. If the fetus has any of these high risk tests positive, you will not give her cerclage, right. So at 11 to 14 weeks, when you are sure that these tests are negative, you will give her cerclage, okay. This is history indicated. Ultrasound indicated is a woman in which the ultrasound shows your cervix to be less than 25 mm at less than 24 weeks, okay. And why are you doing this ultrasound? In any woman? No. So a woman who has given you a history that she had 1 preterm birth or 1 second trimestral loss, in that woman you did the ultrasound, you saw the cervix is short, then you gave the cerclage. That is ultrasound indicated cerclage, okay. So remember, ultrasound indicated cerclage is given in women who has history plus short cervix both, right. Okay, so a woman who has 1 preterm birth or 1 second trimestral loss and ultrasound also shows short cervix of less than 25 mm, then you will give cerclage, right. If a woman has no history, only the ultrasound showed incidentally the cervix is short, will you give her cerclage? No, that is not an indication for cerclage like in the women in question, okay. So you will not give her. Now important is what are contraindications of cerclage. So active preterm labor, if she has entered active preterm, cervix is more than 5 cm, you will not give her cerclage. Chorioamnionitis, vaginal bleeding, rupture membrane, that was the option in our question. In rupture membrane, you will not give cerclage. Okay, evidence of fetal compromise, lethal fetal defects and fetal death, you will not give cerclage. Okay, options were advanced maternal age, it's not a contraindication. Rupture membrane is a contraindication. What about membranes bulging in the vagina? Membranes bulging in the vagina, it means now she needs an emergency cerclage. If she has entered her active labor, it means if she is more than 4 to 5 cm, you will not give cerclage. But it's not open yet, it is saying just bulging of the vagina, membranes of the vagina. It means patient can anytime go into preterm labor. So here you will give the cerclage which is called as emergency cerclage. Emergency cerclage is given when cervix is mildly open and the membranes are bulging out, okay. Then you give emergency cerclage at less than 28 weeks. Why? Because if she is more than 28 weeks and membranes are bulging, if she goes in labor, then the baby could be still saved, okay. So at less than 20 weeks, you can give emergency cerclage if membranes are bulging, okay. This is an indication for cerclage, not a contraindication. What about positive fetal fibronectin? Now fibronectin is a test for fetal preterm labor. So if positive fetal fibronectin is there, it means patient is going in preterm labor. Will you not give cerclage? Okay. So see, basically fetal fibronectin is of significance after 20 weeks. Now it is a glycoprotein which is acting as a glue between this chorion, placenta and the decidua. The chorion is fetal part, decidua is maternal part. So it is acting as a glue in between. Okay. So before 20 weeks it is being secreted by in between the layers and it can be seen in the vaginal fluid. Okay. But after 20 weeks, if it is seen in higher amount, what is the amount? More than 50 nanogram. So if it is seen more than 50 nanogram after 20 weeks, it means there are chances that patient might go into preterm labor. Okay, then instead of giving cerclage, you will give her management for preterm labor by giving tocolytics and steroids. Right? At 18 weeks, this test has no significance. Right? Next question. 22-year-old type 1 diabetic mellitus patient, after cesarean due to severe preeclampsia, she complains of drowsiness and altered sensorium. Okay, so she is diabetic and she has undergone cesarean. Now she is telling you altered sensorium. She is on Maxelf because of severe preeclampsia and on insulin also. Right. On examination, her pulse is 70, BP is 140, 98, respiratory rate is 10. It is very less. On auscultation, her lungs show bilateral normal air entry. Abdominal examination shows firm uterus normal. Scar is normal. Bilateral patellar reflex is absent. So, important is this. Now, urine dipstick shows protein and sugar are negative. Capillary glucose is 270. So, it is high. What would be the diagnosis? So, is it postpartum eclampsia? Postpartum eclampsia will present like this. The patient will have very high BP, isn't it? Also, patient will have convulsions or coma she will be having, isn't it? So, patient will not have drowsiness. So, patient will have proper convulsions and coma with high BP, high urine proteins. That's how patient will present, okay? Magnesium toxicity, it can be because bilateral patellar reflex is absent, which is very characteristic of Maxwell toxicity. Also, respiratory rate is low. In Maxwell toxicity, respiratory depression occurs. So, this might be the answer. Peripartum cardiomyopathy will not present it like this. Okay, it's a cardiac failure, will have cardiac symptoms. So, we'll discuss how it presents. Is it DKA, diabetic ketoacidosis? It can be because she was on insulin, she is type 1 diabetes, sugar is high. But how does a DKA patient present? Presents as polyuria, polydipsia, right? Patient will have tachycardia. She'll not have 70 beats per minute. She'll be hypotensive. Okay, that is how she will present. She'll have ketones in her sugar, high glucose in her urine sugar, right? She will not present like this. So, it is magnesium toxicity. Why it is not peripartum cardiomyopathy? Because peripartum cardiomyopathy presents with dyspnea, chest pain, orthopnea, cough, palpitations. Signs will be tachycardia, hypotension, bilateral creps will be there, murmur will be there. Okay, that is how the patient will present. So, this patient is not of peripartum cardiomyopathy. Now, important diagnostic criteria of peripartum cardiomyopathy, why I am telling you? Because the question was asked just few years back on diagnostic criteria. So, peripartum cardiomyopathy means cardiac failure from last trimester up till 5 months post delivery. That is the duration that was given in the option. From last trimester up till 5 months of the delivery. Then the next thing is you will not find any cause of the heart failure. Also, patient will not be having any pre-pregnancy heart disease, she will not be having, and you can see the left ventricular failure in form of less ejection fraction or less diastolic pressure, or sorry, more end diastolic volume. You will see that there is left ventricular failure. So, these four are the diagnostic criteria of peripartum cardiomyopathy. Okay. Now, let's get back to the question, the Maxelf. So, the Maxelf is a drug for treatment and prophylaxis of eclamptic convulsions. The therapeutic level is 4 to 7. That is enough for prevention of convulsions. Now, if this level is increased, you can have symptoms of toxicity. First is at 10 milliequivalent loss of patellar reflex. So, loss of patellar reflex is the first sign of the Maxelf toxicity. Okay. More than 10, it will lead to slow breathing like our patient was having, and at 12 will have respiratory arrest, at 20 will have cardiac arrest. Okay. So, these all can happen with Maxelf toxicity. So, how will you monitor a patient if you are giving Maxelf? By 3 things. By measuring her deep tendon reflex, by measuring her respiratory rate, and by measuring her urine output. So, these are the signs of toxicity. This will show you. Why urine output? Because if her urine output is less, the chances of having higher Maxelf level is more. That is why you check for urine output also. How will you treat? By calcium gluconate or calcium chloride 1 gram IV and stop the max self. Okay. Yeah. Next question. 34-year-old woman develops preeclampsia at 28th week. Yeah. So one thing I want to tell you, that if you don't have time and you want to cover the chapter of medical complications, 2 medical complications you have to revise, you cannot go without them, is hypertensive disorders and liver disorders. Repeatedly questions are being asked from these 2 topics. Okay. Yeah. Question. Preeclampsia at 28 weeks, she is having anxiety for this development. Obstetrician counseled her that she has abnormality in development of maternal fetal circulation. Okay. What will be the cause? So, she has preeclampsia, obstetrician has told you, has given her enough knowledge that she has problem with the maternal fetal circulation. What is the problem? Poor invasion of extravillous trophoblast, by extravillous trophoblast of aqueous arteries, poor invasion by extravillous trophoblast of spiral arteries, poor invasion by villous trophoblast of spiral arteries or radial arteries. So first you have to know that what structure is invaded by what. Okay, so trophoblast is invading which arteries and which trophoblast. So see, placenta formation starts, trophoblast starts differentiating into syncytial trophoblast and cytotrophoblast. So trophoblast is the layer which forms the placenta. Inner cell mass forms your embryo. So trophoblast start forming syncytial cytotrophoblast, which develops villi. It starts happening 8th day post fertilization. So villi starts forming and these intravillous spaces are created, which are eventually filled with maternal blood. Okay. So that's based on what structures are being formed, we can very well differentiate the trophoblast into villous trophoblast is the one which are forming these villi. Next is interstitial. Interstitial means which is forming these framework on which these villi are lying. Next is endovascular, means those trophoblasts which are invading your arterioles. So villous and these 2 are together called as extravillous. Okay, so we have villous and extravillous are basically interstitial and endovascular. Clear? So this is what is happening. So this villi is formed by villous trophoblast. Okay, now this red color is nothing but your interstitial trophoblast. Can you see these arterioles? These spiral arterioles, this is a maternal side. This is your fetal side. Okay, these spiral arterioles is being invaded by these blue colored cells. Can you see? So these blue colored cells are nothing but your endovascular trophoblast. Okay, now endovascular and interstitial are both together called as extravillous trophoblast. Okay. So what is they doing? This trophoblast is going and invading the spiral arterioles and converting it from thin high resistance channel to low resistance channel. That is the work of trophoblast. Okay. So that is what it is doing. Now the trophoblastic invasion occur in 2 waves. One wave is at 8 to 10 weeks when the spiral arterioles of the endometrium, so of the endometrial region, are invaded. That is first wave. Second wave is between 16 to 18 weeks when the spiral arterioles of the myometrial region are also invaded. Like here, in a normal pregnancy, can you see this trophoblast is invading these arterioles so beautifully? So when it is invading the endometrial area, it is first wave, and can you see when it is invading this small myometrial area also, that is second wave. In non-pregnant, these spiral arterioles are like this. There is no invasion, there is no dilation. What is happening in preeclampsia? First wave is happening normally, but second wave of this myometrial invasion is not happening. That is why there is vasoconstriction and the fetus does not get enough blood supply, leading to all complications of preeclampsia. So what is invading? The extravillous trophoblast is invading your spiral arterioles, right? This is your arcuate artery. This is not getting invaded. Your spiral arterioles are getting invaded. So your answer was extravillous trophoblast, or you can say more specifically endovascular trophoblast is invading spiral arterioles. When that is abnormal, the second wave of invasion is abnormal, it is leading to preeclampsia, right? Okay. Next. So we have done that. So poor invasion by extravillous trophoblast of spiral arterioles. A 34-year-old woman was advised for ultrasound Doppler and dual marker at 11 to 14. What would be Doppler of uterine artery help to predict? Okay, so uterine artery Doppler, when done at first trimester, what index you specially see in uterine artery? Pulsatility index. So pulsatility index will tell you the flow around uterine arteries. You can see due to invasion, the PI has to be less because the invasion of trophoblast occur As a result, the resistance of uterine vessels become very less. Okay. Now, it has been seen that in first trimester, almost 50% of women have abnormal uterine artery pulsatility index. There is abnormal notching which is seen. So, this uterine artery Doppler is not very specific. But if it is seen, then you have to think of something that patient is maybe at high risk of certain diseases. So, if the uterine artery flow is abnormal, it means there is high resistance in uterine flow. Then there are chances of what we have just read, preeclampsia, early onset preeclampsia. But there are also chances of IUGR and abruption. Okay. Now, since IUGR and early onset preeclampsia are both in the option, I did extensive research and realized that if uterine artery Doppler is abnormal, the higher chances of early onset preeclampsia are there. IUGR can also be there, but it is more specific for early onset preeclampsia. Okay. Next, a woman G2P1 at 28 weeks, her uterus is 24. Okay, so it's not corresponding with the gestation. Ultrasound shows absent liquor. Which of the following will be the most likely cause? Okay, so absent liquor is there. So basically, Anhydramnios they are asking. Oligohydramnios means when your single deepest pocket is less than 2 cm. Anhydramnios means when you cannot find any amniotic fluid pocket. That is anhydramnios. Now, oligohydramnios can be early onset or late onset. So let's see first of all what it is. So when there is abnormal urination of the baby, then only early onset oligo or anhydramnios occur. If it occurs late, after mid-pregnancy, then there are chances of placental abnormality. Either there is preeclampsia or there is some placental abnormality or fetal growth restriction. That is more the chance if it is presenting late. Now, it has been seen that before 18 weeks, the fetal skin diffusion is the source of your amniotic fluid. After 18 weeks, fetal urine is the major contributor of amniotic fluid. So, if it is seen that in early pregnancy, before mid-trimester, if it is seen that amniotic fluid is less or absent, it means there is a problem with fetal urination. Okay. So, the causes of early onset anhydramnios or severe oligohydramnios are same, which is bilateral renal agenesis, bilateral multicystic dysplasia of kidney, unilateral renal agenesis can also present with severe oligo, or bladder outlet obstruction. Means urine formation is normally occurring, but baby is not able to urinate, like posterior urethral valves, urethral atresia or stenosis. They all will lead to mid-trimester anhydramnios. Okay, so let's get back to the question. Yeah, congenital heart disease, no. Hydrocephalus, no. Fetal renal anomalies, yes, that is the cause of 24 weeks anhydramnios. Next question, primary gravida delivers her baby by vaginal delivery at village health center. After 1 hour, baby is doing well, but mother is hypotensive, hypoxic and showing features of DIC. Okay, hypotensive, hypoxic and DIC. Most likely cause, is it PPH? PPH can definitely present with DIC. Amniotic fluid embolism, it can also present. Abdominal distension due to uterine rupture. So, uterine rupture will lead to excessive bleeding, then can lead to DIC. Peripartum cardiomyopathy. Let's start one by one. Peripartum cardiomyopathy will not present with DIC. We have discussed. There is characteristic paroxysmal nocturnal dyspnea, tachypnea, cough, patient will be tachycardic, patient will have murmur, basal creps, all this will be there. Okay, patient will not present like this, right? So, this is not peripartum cardiomyopathy, DIC will not be there. Why not postpartum hemorrhage? Because in postpartum hemorrhage, DIC occur because of 2 reasons. Excessive bleeding leads to your consumptive coagulopathy, leading to DIC. When you resuscitate with fluid, so this excessive fluid also lead to dilutional coagulopathy. So, if history gives you that there is excessive blood loss, you gave fluid resuscitation, then patient had DIC, answer would have been PPH. They have not mentioned that there was excessive bleeding and fluid resuscitation. Patient was just hypotensive, hypoxic and a DIC developed. Okay. So, in that case, PPH will not be your answer. Okay. Abdominal distension due to uterine rupture. Now, uterus rupture will not present after 1 hour. It is an acute presentation. Patient will be immediately hypotensive, hypoxic and will have DIC. Okay. So, it is not will be seen after 1 hour. So, this is also done. Answer is amniotic fluid embolism which presents with DIC. Why the DIC is occurring? So, basically, due to some of the factors which we will discuss, there is release of tissue factor from our blood vessels. As a result, there is endothelial activation and diffuse activation of the coagulation system. Because of tissue factor, diffuse activation of coagulation system occur, and there is a usage of all the coagulation factors occur. As soon as all coagulation factors are used, it leads to excessive bleeding and what we call DIC. Okay, so consumption of coagulation factors and platelets leading to bleeding. So that is DIC, right? So lot of obstetrical factors can lead to DIC. The most common is placental abruption. So placental abruption is the most common cause of DIC. Then preeclampsia, eclampsia and HELP due to endothelial activation. Then prolonged retention of dead fetus. Next is what was in our question, amniotic fluid embolism. Now amniotic fluid embolism, there is release of the fetal tissue into the maternal vessels which lead to sudden inflammatory response, again endothelial activation and tissue factor release. Okay, that's what is happening in amniotic fluid embolism. This amniotic fluid embolism has a classical triad of hemodynamic and respiratory compromise with DIC. So hemodynamic compromise, respiratory compromise and DIC. Okay, sepsis is also another cause of DIC. Now, how will you diagnose amniotic fluid? First of all, amniotic fluid embolism is a clinical diagnosis. Sometimes you can see the signs of amniotic fluid embolism in postpartum, but you generally don't go that far. It is a clinical diagnosis. What happens is there will be abrupt onset of cardiorespiratory arrest or hypovolemia and respiratory compromise. There will be DIC. You will detect coagulopathy. Okay, before excessive bleeding occur, you will detect coagulopathy, and there will be no fever. Okay, so there will be no fever. That is the triad of DIC. Now, amniotic fluid embolism. What is the pathophysiology? That there is disruption of maternal fetal interface. Okay, so immediately after delivery, fetal material enter the maternal circulation. There is activation of pro-inflammatory markers leading to pulmonary vasospasm. Now, pulmonary vasospasm occur due to which there is respiratory compromise. So, remember our patient was hypoxic. Okay, as pulmonary vasoconstriction occurred, that leads to right-sided ventricular failure. When right-sided ventricular failure occurs, there is movement of interventricular septum leading to left ventricular failure. As a result, there is cardiogenic failure. So, patient is hypotensive also. So, bleeding is not seen. Till DIC develops, bleeding is not seen. Patient will have hypotension, patient will have respiratory compromise, and because of pro-inflammatory mediators, patient will have DIC. After that, patient will start bleeding. That is the presentation of amniotic fluid embolism. So, that was our answer. Okay, amniotic fluid embolism. She was hypotensive, hypoxic and DIC. Okay. Next question. A primary gravida presented to labor room at 40th week of POG. She has been in labor for 3 hours. Okay, which among the following determines she is in active phase? So basically they want to know whether you know when the active labor starts. Rupture of membrane. Is rupture of membrane sign of active labor? No. 2 contractions each lasting 30 seconds. So contractions will not tell you whether she is in active labor. What will tell you exactly? Cervical dilation. So labor is from start of uterine contractions to cervical changes. So from start of uterine contractions with cervical changes is start of your labor. Active phase starts from 6 cm by ACOG and 5 cm by WH. Okay, so when 5 to 6 is your cervix, it is active phase. Okay, so cervical dilatation more than 5 is basically active phase. In active phase, contractions are very good, but they are not diagnostic of active phase. Good contractions means 4 to 5, not 2, 4 to 5 of almost 40 seconds in every 10 minutes. That is the good contraction that is occurring in active phase. Okay, head is 5 by 5 palpable. 5 by 5 means head is freely floating. So it is not seen in active phase. Even if head is engaged, that is not a sign of active phase. Active phase means cervical dilatation more than 5 cm. Now, next question. 34-year-old G2P1 present at 35 weeks with previous history of classical cesarean. Currently, she is having no complaint. Now, she is 34 weeks. She is having low dose aspirin. So, I tell you, I have reduced this question. It was a heavy question. The question it was given, she was severe preeclampsia. That is why cesarean was done. And that is why she is on low dose aspirin right now. On examination, uterus is 38 cm, fetal heart is normal. Ultrasound shows single live fetus breech. Okay. With normal placenta and amniotic fluid. Now, patient wants normal delivery. What will be the next step? Schedule her for elective LSCS, external cephalic version at 36 weeks, await spontaneous labor and then do internal podalic version, review ultrasound. Important is she is breech. Okay, but she had previous classical cesarean. So now her condition changes. You can try normal delivery in any breech, but you have to rule out contraindications. Okay, so ECV at 36 weeks. So external cephalic version will be done in a breech patient at 36 weeks. That's right. In any patient in which you will try for vaginal delivery. The contraindications of ECV are conditions in which you know that vaginal delivery cannot be tried, like classical cesarean. Classical cesarean is an absolute contraindication for vaginal delivery, isn't it? Why will you try ECV in such a patient? You will not try. She cannot undergo normal vaginal delivery. Then will you await for spontaneous labor and then do internal podalic version? Only indication of internal podalic version now is delivery of second twin. You do not do it in any patient. This is gone. Review ultrasound. Yes, if a breech is in labor, you will do a review ultrasound to rule out all the contraindications, and if there are no contraindications, you can trial for breech vaginal. But this patient is contraindicated for vaginal. You are not trying for vaginal in a patient of classical cesarean. So you will not do this. You will straight away take her for elective LSCS. Okay. So classical cesarean cannot go for normal delivery. You will do this. What about if she would have been normal cesarean? So if she would have been a lower segment cesarean section, then will you have tried for a breech vaginal delivery? No. Even if the classical cesarean is not mentioned, lower segment cesarean is mentioned, then also your answer will be elective LSCS, because it has been asked previously also that trial of breech vaginal delivery, the contraindication is previous LSCS. Be it classical, be it lower segment. In previous LSCL, you will not try a breech vaginal. Okay, this is a past question. Trial of breech vaginal delivery is avoided in footling breech, incomplete breech, in cord presentation, in hyperextended neck, in a heavyweight baby or IUGR baby. That is why you were doing this ultrasound. I told you after ultrasound is done at term to rule out hyperextended neck and IUGR and footling presentation. To rule out these, you will do ultrasound. Clinically inadequate pelvis, prior perinatal death and trauma, and absence trained personnel. In all these conditions, you will not even try for vaginal. Okay? Right. Next question. 36-year-old G3P2L2 presented at 7 weeks and seeking for medical termination of pregnancy. As per CAC guidelines, what drugs would be used? Okay, so CAC is Comprehensive Abortion Care Guidelines, what drug is to be used. So she is 7 weeks. Mifepristone, meso, methotrexate, mifemethergine, mifemedroxy. It is very easy. Mifepristone and mesoprost is advisable by CAC guidelines. Now, previously also a question has been asked in INICT that what is the method of abortion in first trimester. So method on abortions have been asked very frequently. So I want to just give you a little idea about CAC and WHO. CAC is Comprehensive Abortion Care Guideline by India. Okay, so it's an Indian guideline by our Ministry of Health and Family Welfare given in 2018. Now WHO is a universal international guideline, recently updated in 2021 also. Okay, so they differ a little in what they advise. Okay, why you need to know both? Because when the question in INICT was asked that which of these is not a method of abortion, some methods were picked from here and some from here. So you should know both of them. So first trimester, let's see what CAC says, let's see what WHO says. First trimester, medical abortion is advised till 9 weeks according to CAC. It's not 7, now they have updated it to 9 weeks. So till 9 weeks, you can do medical abortion according to CAC. Okay? And now CAC, Indian guidelines are generally very simple because you have to explain it to a ANM, to a village health guide. You keep them simple. So only one method of medical termination of pregnancy, and that is mifepristone and mesoprost. Mifepristone 200 milligram. So if it is less than 7 weeks, the dose is 400. And if it is 7 to 9 weeks, the dose is 800. Simple. So only these two drugs is used. The protocol is give mifepristone on day 1, wait for 24 hours, don't do anything on day 2, and on day 3 give misoprostol. Okay, the patient will abort, call her after 15 days for follow-up, and you see that she has aborted. That is the simple protocol of CAC. WHO says 3 methods of first trimester abortion. You should know all the methods by name. Mifi-meso, correct. Meso alone, though less efficacious, it is 95% efficacious, and it is less efficacious, almost 80 to 85%. but it is a method which can be used. New method in new guideline is letrozole plus meso. So letrozole plus meso is also another method of contraception in first trimester. Okay, this is by WHO. Surgical method in first trimester is vacuum aspiration by CAC and WHO both. They say in first trimester you can use vacuum, either manual vacuum or electric vacuum, it doesn't matter. You can use any of the vacuum in first trimester. So that is the only surgical method for first trimester, vacuum aspiration, no DNC and all. Simple. So you got it. By CAC, one method for medical termination. By WHO, three methods. Surgical method is one, vacuum aspiration. Second trimester. In second trimester in India, do we give medical method? No. According to CAC, the medical method is not given in second trimester. But WHO says you can safely give medical method in second trimester. Same three options: MIFI plus meso or letrozole plus meso. You can give all. Okay. So they say that medical abortion can be done in second trimester, but CAC says that the age limit for medical abortion is 9 weeks. Okay. The surgical methods in second trimester by both CAC and WHO is dilation and evacuation, not curettage. Curettage is not done. So dilate the cervix, evacuate. How do you evacuate? By using vacuum, then using forceps, again vacuum, forceps. So see, 12-week baby has fetal parts. It's a big baby. You cannot suck out everything by just vacuum. That is why in second trimester you need dilation and evacuation. So evacuation is done using partially vacuum and partially your ovum forceps. Okay, curettage is not done. So this is the surgical method, dilation and evacuation. Okay. Now miscellaneous methods are mentioned only by CAC guideline, not by WHO. Certain miscellaneous methods for second trimester are hypertonic saline, hyperosmolar urea, intraamniotic, ethacrydine, extine intraamniotic, prostaglandin analogs, oxytocin. They all are invasive method, less efficacious and not very effective and little harmful, not very advisable, but does mention their name. Even ethacrydine is not very easily available in India. Okay, so they are the last options which you have to choose. But yes, CAC does mention that these can be used for second trimester abortion. Okay, so I hope I am clear. Next question. Priming gravidite at 34 weeks presented with jaundice and BP of 140/90. I told you in medical problems in pregnancy, do read hypertensive disorders and liver disorders. So she has jaundice and BP is high. Her blood investigation shows serum bilirubin is okay, 1.5. SGOT is high, SGPT is high, LDH is high, 70. And her platelet count is also less, 75,000. Her KFT is normal, coagulation is normal. What is your diagnosis? Viral hepatitis, acute fatty liver, HELP syndrome, intrahepatic cholestasis of pregnancy. So basically they are asking generally about liver disorders in pregnancy. So see, liver disease which can complicate pregnancy are divided into three parts. One is those conditions which are specifically related to pregnancy. They will develop only in pregnancy. So they are namely three. So first of all, the most common is intrahepatic cholestasis of pregnancy, which is occurring only in pregnancy. Then is an emergency condition which is AFLP, acute fatty liver of pregnancy. Third is HELP syndrome. HELP syndrome is a variant of severe preeclampsia, but it is occurring in pregnancy only. Okay, when it involves liver and other system, it is HELP syndrome. So this is one condition. Another second category is your acute hepatic disease which is coincidentally occurring in pregnancy, like acute viral hepatitis. Okay, so it is not related to pregnancy, but it has occurred by chance in the pregnancy. That is your second category. Third is you have a chronic liver condition now which is exaggerated because you are pregnant. Okay, so chronic liver disease or chronic hepatitis which is escalated because you are pregnant. Okay, it is stress on the liver. That is your third category. Okay. So basic liver conditions which are commonly encountered in clinical practice and commonly questioned are this and hepatitis. Okay, acute viral hepatitis. So these are the common conditions which are encountered, and that we'll see how we will differentiate between them. So cholestasis and fatty liver present late in trimester. Preeclampsia can be mid to late and hepatitis can be present anytime. Okay, it is not trimester related. Cholestasis will characteristically be having pruritus, jaundice is plus minus. AST-LT is raised but almost 200, not very high. Bilirubin is also not very high. Fatty liver is an emergency condition. Patient will have nausea, vomiting, hypoglycemia is a very characteristic. Patient will be very hypoglycemic. Hypertension and liver failure will be there. AST is high. Since it's liver failure, but it is not very high. It is 200 to 800. Normal AST level is less than 40. So it is 200 to 800. Bilirubin can be 4 to 10. Creatinine is very high in acute fatty liver. Remember, it's an emergency. Preeclampsia means HELP syndrome. Will have headache, will have hypertension, will have urine protein. Simple. Then AST will be almost 300. Okay, creatinine might be high. Important, hepatitis. Hepatitis has very high AST. When you see your AST levels 2000, jaundice. Sometimes jaundice will even be minus. There is something called as anicteric hepatitis. Okay, so jaundice might be there, might not be there. But such a high AST, think of viral hepatitis. Okay, if hypertension is there, headache is there, AST is raised, think of HELP syndrome. If patient has nausea, vomiting, she is hypoglycemic and AST is 200 to 800 and creatinine is high, since think of AFLP. Okay. Now, so SGOT-PT is 150 200, not very high. So you can remove viral hepatitis from here. Platelet is less, LDH is high. Okay. So it seems to be HELP syndrome. Platelet and LDH will not be affected in intrahepatic cholestasis and acute fatty liver, right? Okay. So let's start with HELP syndrome. HELP syndrome is a variant of severe preeclampsia with a characteristic triad. All the three parts of this triad are there in HELP syndrome. Hemolysis, elevated liver enzyme and low platelet. Okay. Hemolysis, microangiopathic hemolytic anemia is there basically. So hemolysis can be seen by any sign. Either patient is anemic or LDH. So RBC has its own enzyme LDH. LDH is high. Normal LDH is 280 units per ml. So if LDH is high, that's a sign of hemolysis. So either anemia or LDH is high or haptoglobin is low, or you see on histopathology cystocytes or bird cells which shows hemolytic RBCs. They all signify hemolysis. So hemolysis will be seen. Elevated liver enzyme we have seen AST, ALT, but it is generally 2 times the normal. Less than 200, it's not very high like hepatitis. Low platelet is less than 1 lakh. When all three are present, it's HELP syndrome. If patient is more than 34 weeks, HELP syndrome is an indication for delivery. Okay, if she is more than 34 weeks. If she is less than 34 weeks, you see HELP syndrome is there, admit her, give her steroid and induce her within 24 hours or second dose of steroid. Okay, so if you have time and patient is less than 34 weeks, give her steroid. Okay, start with Mexelf, give her steroid, after second dose induce her. Except in certain conditions in which you see that condition is very worse, like pulmonary edema or uncontrolled hypertension or placental abruption and non-reassuring fetal heart rate. In that case, you will not wait for steroid, you will straight away induce. Okay, this is how you manage HELP patient. Yeah. Next question. 22 8-year-old woman who delivered 18 months back and breastfeeding is seeking contraception. Her periods are irregular and heavy. What will you give? Now she is 18 months. It means you can give anything in her. It has been 1.5 years since she has delivered. So all the contraceptive methods can be given. The choice will depend on that her periods are irregular and heavy. So what will you give? Will you give Malayan? Will you give norethistron enanthate? Will you give copper T 380A or progesterone? So copper T will further make her periods irregular. Then progesterone pills or progesterone means IUCD, progesterone releasing IUCD, they will make her completely amenorrheic and she will have off and on spotting. That will not make her periods regular and normal. The only thing that can help her in this case is OCP. So OCP will make her periods regular and decreased in amount. Okay. Since she is 18 months, she can use anything. Quickly, I want to tell you here the postpartum contraceptives. So see, patient has delivered, she does not need anything for 21 days. For 21 days, for 3 weeks, no contraception needed in all the patient. She will be feeding, she will not be feeding, doesn't matter. 3 weeks, don't do anything. Now, further divide women into exclusively breastfeeding and non-exclusively breastfeeding. If a patient is exclusively breastfeeding, you further don't need anything for 6 months. And after 6 months, she can use anything. Okay. If patient is non-exclusively breastfeeding, it means either she is not breastfeeding at all or she is breastfeeding but it is not exclusive. In both these cases, start the contraception after 21 days. She can get pregnant. After 3 weeks, you need contraception. But what will you give? If a patient is not breastfeeding, you don't have to think much. You can give her any method, any method. But if a patient is breastfeeding, you will not give her one thing which will affect her breast milk, that is OCPs. You cannot give her OCPs till 6 weeks. Till 6 weeks you cannot give her OCPs. Everything else, progesterone implant, DMPA, copper IUD, everything else you can give in her. Okay, so this is the postpartum contraception. Sometimes it is asked, okay, for 21 days we do not need any contraception. But still if it is asked, if any immediate contraception has to be started, what all you can give? So immediate contraception you can give IUCD, progesterone implant, DMPA, but you cannot give what? OCPs. Why? Because initial postpartum days, OCPs increase your thrombogenic risk. So in immediate contraception, OCP is not preferred. Everything else can be given. Okay, simple. Next, a woman at her 22 weeks presented with profuse vaginal bleeding. Her BP and blood glucose are normal. What will be the likely site of ectopic implantation? So they've given you ectopic implantation with profuse vaginal bleeding. Is it tubal, abdominal, ovarian, internal os? Okay, so by presentation you have to tell where the ectopic pregnancy is lying. So see sites of ectopic and let's see how they present. Tubal ectopic is seen in 95% of patients and the typical triad is absent menses, pain and spotting. There is no profuse bleeding. So spotting is there. So tubal is gone. How will you diagnose? Previously for ectopic pregnancy diagnostic was said to be histopath. But now it is not so. Diagnostic is TVS. TVS is diagnostic of any ectopic pregnancy. Okay. How will you manage? Tubal ectopic can be managed by conservative method, methotrexate or surgical depending on beta HCG levels. Right? Ovarian, like that of tubal, it will present with absent menses, pain and spotting. Patient will characteristically can give history of ART. Okay. Diagnosis by again TVS. The criteria, the features seen of ovarian ectopic are given a criteria named Spiegelberg criteria. Why I am giving you? Because a question was asked that what is the criteria for ovarian ectopic diagnosis? It is Spiegelberg criteria. The question was asked on this name. So just know the name. Okay. How will you manage? For ovarian ectopic, you will not be able to give medical treatment. The answer is veg resection or oophorectomy. You have to do the surgery. Cervical, it means the ectopic at cervical, patient will have painless vaginal bleeding. In fact, 1/3 of the patient will have profuse vaginal bleeding. Okay, that's how it presents. Diagnosis is by TVS, 3D ultrasound or MRI. Now, if an ectopic is there at the cervix, it could also be an abortion. It could be. How will you know? So, there is a sign on TVS called a sliding sign. If you press the TVS probe, you will see that if your tissue slides, it means it is an abortion going on. It is not ectopic. If on pressing the probe, the tissue does not slide, means sliding sign negative is a sign of cervical ectopic, absent sliding sign. Okay. Treatment. Now you can see the G-sac, it's at the cervix. Either you can directly inject methotrexate or you can give methotrexate injections. You can also go for suction evacuation and maybe hysterectomy. Okay. Since the name was asked for Spiegelberg criteria, we should know other criteria. Rubin criteria is the diagnostic of cervical ectopic, but it's a histopathological criteria. Okay. Histopathological criteria. Next is abdominal ectopic. It's a very vague science, very difficult to diagnose even on ultrasound. It is difficult to diagnose and difficult to manage. The diagnostic criteria is Studiford criteria. So Studiford criteria is the diagnostic criteria on TVS of abdominal, primary abdominal. Primary abdominal means ectopic started in the abdominal cavity only. Secondary abdominal means the pregnancy started in the tube but eventually it went and implanted in the abdomen. That is secondary ectopic. She had profuse vaginal bleeding. Site could be tubal, no. Abdominal, no. Ovarian, no. Internal os. Said cervix. So this covers all of our NEET 2022 topics. Go through them really nicely because they, trust me, more than 50% questions will be from these similar topics. Okay. Best of luck for your next NEET.